So we're continuing with the treatment of obesity, and I'm going to talk about a couple of different approaches or things that I just wanted you to keep in mind. One is the non-diet approach. A couple of people I know, Becca Clegg and Anita Johnston, have written really good books on the non-diet approach. The first person that I knew about who advocated this approach and wrote a book about it is Evelyn Tribole. She wrote a book that's really popular called Intuitive Eating. Anita Johnston, this book is targeted more towards females. It's called Eating in the Light of the Moon, and it really addresses some of the emotional issues that contribute to overeating. And Becca Clegg wrote a great book. It was published last year, about a year ago, maybe, called Ending the Diet Mindset. I found that book, I reviewed the book, and I found it really, really good, easy read. She's a storyteller, which is a really engaging writing style, and she talks about her own experience. Anita is a psychologist. Becca is a counselor who they both work with people with disordered eating. So Ending the Diet Mindset is really good for people who got on that cycle of dieting and have developed an unhealthy relationship with food. So the non-diet approach is really good for people who've developed an unhealthy relationship with food, especially from chronic dieting. With intuitive eating, no foods are restricted. Basically, and they focus on listening to hunger and satiety cues and trying to really figure out what the person tries to figure out what they really want to eat. And they find that for a lot of people, ditching the dieting and focusing on, not depriving of favorite foods, actually normalizes eating behaviors or results in healthier eating behaviors and a better relationship with food and body as well. So this is an approach to think about. Now, if somebody has a true eating disorder, a lot of times at first they start off with a structured meal approach, and gradually as the person's appetite regulation mechanisms recover, they transition to the intuitive eating approach. Structured eating, well, that kind of follows because sometimes that can be the first step towards if your relationship with food is really unhealthy or your eating is really chaotic. Some structure sometimes helps you get to the point where you can get to that non-diet approach or the intuitive eating approach. So some structured eating, there are meal replacements, or in some structured eating approaches, you eat kind of the same thing for certain meals. I know that there's a program that somebody I know has been on. It's a commercial program where the program actually provides the foods. It's called SODA, and the person that I know has lost 150 pounds. So this person needed some structure as he was getting the nutrition education and support he needed to change his lifestyle. They also have, exercise associated with that program. I'm not endorsing any one program, like I said, because the same approach does not work for everybody. So what happens is you have kind of a decision-making bank for the day, and you wake up with your bank full. And so people are usually make, wiser decisions, in the early part, mid part of the day, but they develop decision-making fatigue later in the day. So people tend to make worse decisions about eating choices in the evening, okay? Same thing happens with a discipline bank. You start off, with your discipline bank full in the morning, and then, you can be really disciplined about work and eating and all that in the early part of the day, but then again at night, your discipline bank is running on empty, and, you don't have as much discipline around food. And so, these are some of the reasons that, not having a lot of choices around eating can be helpful, at least at first. I know, I had 115 pounds to lose, and and I had developed the really chaotic eating behaviors because of that cycle of dieting. So I didn't know that I was doing something structured, but I ate the same exact thing for breakfast and lunch every day for a couple of years, and then gave myself a handful of choices for dinner. And that really helped set some better eating habits. So the structured eating plans with support can help change some eating habits. Physical activity is essential. Now, when someone's 100 pounds overweight, exercise is really difficult and uncomfortable. When I first started exercising, as my energy increased when the thyroid was recovering, I thought of physical activity. Well, first of all, I wasn't hard on myself. I didn't do punishing physical activity. I lived in California, so I walked on the beach 3 times a week. How hard is that? And I walked at low tide when the sand was nice and firm and I could collect sea glass and things like that. So, I was kinder to myself this time and gradually worked up to vigorous physical activity. If you're a health professional working with someone, you need to be aware that if somebody is severely obese, anytime they put themselves out there to the public, they're at risk for being bullied. And so, when I was walking on the beach, I got the beach dwell comments. And I know obese people who don't want to go outside because people says, well, anyone can go out for a walk. But there is a hesitancy when you can get clobbered by somebody's comments. The same thing if they have joint problems, but they can swim. Well, getting in a bathing suit when you're severely obese is pretty terrifying to some people. So those are some things to think about when you're recommending physical activity to somebody who's severely obese. But for weight loss and maintenance of weight loss, 300 minutes or 5 hours per week of moderate exercise is associated with weight loss and maintenance of weight loss. That's double what the person without obesity needs or is recommended to have. You can cut that in half if the exercise is vigorous, but it will take a while for the person to get to that vigorous level. Now, when exercise was really unpleasant for me, I thought of it as physical therapy. It was something that I needed to do for my body type. And that change in perspective or reframing does help some people. It's like I brush my teeth because dental health is important to me. I exercise because my physical health is important to me. So I think of it as physical therapy rather than just working out. And I tell myself sometimes when I could go to the gym, when I didn't want to go, at least I'm not going to kidney dialysis appointment, so it's not all that bad. Resistance exercise is important to maintain muscle mass, and again, a reminder, you can't out-exercise a poor diet. So both diet and physical activity are really essential to weight loss and maintenance of weight loss. Now, there are 6 FDA-approved medications for weight loss. Most of them in the studies the average loss is about 5 to 7% of body weight. So that's not a lot, but it's enough to maybe result in some metabolic improvements or give people a kickstart that they need. A lot of them work by appetite reduction. The one that is over-the-counter Ally is available prescription strength. It's called Orlistat. Remember, that's the one that reduces dietary fat absorption, that has those kind of embarrassing side effects if you don't reduce your dietary fat intake with that. But a lot of them work by reducing the appetite. They're not prescribed very much. You have to be on them for a lifetime. And I think some of the reluctance to prescribe them is in the 90s, there was 2 weight loss medications, Redux and Fen-Phen, and they were very effective for weight loss, but they had horrible side effects, heart problems, and a deadly condition called primary pulmonary hypertension in some people. So they were taken off the market. But they all have some side effects. Sometimes it's nausea, for one of them that I'm thinking about. But there are 6 that are approved The issue is you have to be on them for a lifetime, and insurance coverage is variable, so some of them are really expensive. The weight loss surgery, the gastric band was popular for a long time and people lost a lot of weight with it, but a lot of them started gaining it back. And then over time, there seemed to be, for some, they had complications like scar tissue where the band was placed that would kind of, it's called a stricture. It would get really narrow and cause really big problems for them over the long haul. So now more are being removed than placed. So I'm not a fan of the gastric band. In the gastric bypass, the stomach's reduced to the size of an egg, and then the small intestine is detached from the stomach and is reattached so that the food goes from the stomach, bypasses a significant part of the small intestine and goes from that little egg stomach into the jejunum. Okay, so some absorptive area is bypassed. So this is a picture of the actual surgery. You can see, this is the normal anatomy, and you can see here in the green is the new anatomy, where the stomach is a lot smaller and that little stomach goes into the jejunum. There's a new attachment there. And so you can see the duodenum, the largest part of the stomach is detached. The duodenum is still there, and they attach the duodenum to the jejunum so that you can get, that's where, remember the duodenum is where the bile is released and pancreatic juice. So they have to have the duodenum attached to that jejunum. But anyway, the little stomach pouch makes the person feel full faster. And what they found is that when they detach that lower part of the stomach, there seemed to be a change in the appetite regulation hormones that are secreted by the digestive tract so that the person doesn't feel hungry as much for that reason as well. Okay. So the gastric bypass does alter hunger satiety hormone secretion to make the person's appetite lower. Less small intestine is available for absorption. Now, complications are common. The complications can be minor. If the person, after the gastric bypass, eats simple carbohydrates or too much refined carbohydrate, they get what's called this dumping syndrome. Because they no longer have a pyloric sphincter to regulate the flow of food from that little stomach into the jejunum, they absorb carbohydrates really fast, so their blood sugar gets really high, and then insulin's released, and then it could crash, so that they have rebound hypoglycemia and some other issues as well, but they feel horrible. Like they could pass out, really horrible when they have the dumping syndrome. So they have to eat their protein first and be really careful about carbohydrates. There are some people where the jejunum has been attached to that little stomach, the egg-sized stomach that's left. That new connection kind of degrades, and that's a really serious complication. If there's a problem with that, new stitched up connection. Now, there are some good things. It has saved some people's lives. I do know people who've had gastric bypass who have gained the weight back. They had emotional eating issues that were not addressed, or other issues, that were not addressed related to eating. But it can result in remission of type 2 diabetes, at least for a number of years. May come back later, but people with type 2 diabetes seem to be able to go off their diabetes medications, at least for a while. Okay. The gastric sleeve is another popular surgery. It's not as drastic as the gastric bypass. And you can see in the picture that the large part of the stomach is removed. So they call it a sleeve because now the stomach just looks like a sleeve. So they don't do any detaching and reattaching and this surgery. They just cut off that large part of the stomach and take it out. The smaller stomach area leads to a fuller, faster sensation of fullness. Now the stomach is elastic, so it can stretch out over time. But again, the removal of that part of the stomach seems to alter the appetite regulation hormones so that there's less hunger. Again, the weight can be regained. The weight isn't lost as rapidly, and that's not a bad thing. When you lose weight extremely rapidly, the skin doesn't adjust as well, and there's a greater risk for malnutrition. In fact, a lot of people think that most people who lose weight really quickly with gastric bypass, they tend to lose around 100 pounds in the first 6 months, sometimes more. And they're probably, when you lose weight that quickly, you lose muscle mass. So in summary, weight control is difficult for a lot of people for a lot of different reasons. We live in a society where there's food queues everywhere. Food is available and cheap. We've developed a convenient way of life, so we don't need to move much. So we've set up what Kelly Brownell, one of the experts in obesity, calls a food toxic environment that makes it difficult for people with any genetic tendency for weight problems to gain weight. So for people with weight problems, losing weight and keeping it off requires a change in lifestyle that's difficult to maintain, but it is possible. It usually starts with that mental shift that I talked about earlier. Some people who are obese, need to, they think that their self-worth will increase once they lose weight on this drastic diet they're going on and they're no longer, severely obese. But the self-worth actually has to come first. So what are the mental shifts besides this is going to be the way I'm going to live forever with this newer, healthier lifestyle? Self-worth is a mental shift that a lot of people, if you don't like yourself, you're less likely to take care of yourself. People who have good self-worth make the effort to take care of themselves. So this is the last slide. Contrary to what you see in the media, we're not all supposed to look the same. I see a lot of people triggered to go into that cycle of dieting because they have a poor self-image. You need to realize that we're not all built to be the same. And so, good self-care, healthy lifestyle starts with self-worth because people who value themselves are more likely to take care of themselves.